Good morning. Thank you very much. My name is Dr. Bonnie Richardson. I'm speaking from Regina today. I'm an internal medicine doctor, nephrologist, the ADL Department of Medicine here in Regina, and I'm acting in the current capacity of IHEC co-defense chief for the pandemic physician lead. So thank you. So my CQIP project revolved around optimizing anemia in hospitalized patients that are on hemodialysis. So I'll show you my aim statement, and while you're reading my aim statement, which is pretty short, which was a really good learning opportunity for me to really drill that down and see what the actual problem was, I'll tell you a little bit about the way of the background. So what we have on a typical patient comes in very ill, very sick, potentially flown in from STARS, emergency situation, and they're admitted to our intensive care unit. We're worried about cardiogenic shock, septic shock. Often these patients are very ill, intubated, ventilated, on medications to keep blood pressure and cardiac output optimized. So we're very focused when the patient's this ill on optimizing their heart. They're in multi-organ failure. They're often on continuous renal replacement therapy, which is a type of dialysis that runs 24 hours a day, and managing their electrolytes and their acid base. What happens over time, for multiple reasons, is the hemoglobin, which carries oxygen, trickles down. One of these reasons is just that the patients are very, very sick. Another reason is, of course, we're doing frequent blood tests. But a little unknown fact about the kidney is it actually sends the hormonal message over to the bone marrow to make blood cells. So if your kidney's not working, you're not going to be producing the blood cells. The hemoglobin tends to drift down and down and down in these sick ICU patients, even after we get them stabilized, and because we're focused on everything else. Sometimes we don't notice as a team of care providers until that hemoglobin hits this magic number of 70, which means, wow, we need to transfuse. Transfusion is not ideal for any patient. There's numerous side effects and risk to patients giving blood transfusions. Additionally, it's a significant strain on our system cost-wise, but importantly for our kidney patients, if they don't recover from their acute kidney injury requiring dialysis and they go on a transplant, if we've given them blood products, they build up antibodies and they're less apt to receive a transplant in the future. So it's a really big deal for us to identify these patients early on, because there's medications and hormones that we can give to help replace the transfusion. So, and originally when I was looking at this, I was thinking, we just need to be, giving these patients these medications and optimizing them earlier. But really, I think one of the take-homes from this project, I kept hearing, what is the problem? What is the problem? We all want to do the right thing. The ICU, the nurses, the nephrologists, the intensivists. I think what the issue is when we really drilled down for the aim statement, which was revamped a few different times, was identifying the patients. So really what the problem is not that they're anemic, it's identifying them earlier on when to intervene. So the aim statement became, in June 2021, 100% of hemodialysis patients in hospital will be identified early and started on anemia management. So another learning tool for me was the driver diagram. I learned a lot kind of going through these and the fish diagrams and looking at the primary and secondary drivers around optimizing care in these patients. And it's really involving a lot of people and a lot of opportunities in the system and identifying those gaps. We all want to create a culture of safety and quality. We want to improve communication between, the kidney doctor and the ICU team, and we want to be looking at who are the stakeholders in these processes. We've got nurses, we've got pharmacists to help us manage these things. We have our nephrologists, which is our kidney docs, our charge nurse, our hemodialysis charge nurse, our ICU charge nurse. lots and lots of people. And whose role is it? Because what we were kind of finding when we started to do a deeper drive is there's so many people looking at the patient in so many different ways. Sometimes it was confusing to us as a team on whose responsibility that one small piece was to identify these patients earlier. Because the pandemic hit and we got really busy doing a lot of other things, we have revisited this from time to time. What we're looking at is implementing a PPO pathway that's team-based with all our stakeholders to identify these patients earlier, look who's responsible for what at which point in the patient's care journey, and optimize the patients earlier, and then, see what that shows. This was another learning point for me, of course, is quality improvement. We might not get it right the first time around, and that's okay. It gives us the opportunity to go back and see where those opportunities are to improve during our PDSA cycles. Key learning and reflections from this program. I absolutely love it. I think most of all, I really enjoyed meeting some of the people who participated in the program and the coaches and some of the very dynamic lectures. I really thought it was great to connect with people otherwise that I would connect in a normal working day in my department, in my area. I felt one of the learning things for me personally was that what seemed very simple, this project and how to do an aim statement, when you start really drilling down, is a little more challenging than it appears on the surface. And the KISS principle, like keeping it simple, is important. The other thing I learned is that this might be my priority today, but the team has lots of other competing priorities. And we're all interested in quality and safety, but with so many competing priorities in healthcare, how do we drill this down and make it attractive to the stakeholders? The other really big thing for me is quality improvement is not research. I do a lot of research in other areas, and I thought, this is more quality improvement research because I do some of that, but it's certainly not. And there's such a difference. It's very dynamic. It's very fluid, and it's a whole different approach, and it's really, really exciting work. The other thing is I was glad throughout this program that they challenged me. I always joke that I grew up in the age of 1970 in Pong, so I was very glad that this program challenged me to continue to improve my skills using things like run sheets and different programs and audiovisual materials. And I just want to thank everybody else